Our final speaker during this session is going to be Dr. Marcos Delima from the University Hospitals Case Medical Center, Professor of Medicine. His title is Post-Transplant Manipulation in AML.
I see that I have 5 minutes to finish.
A few more.
Three and a half minutes. So listen, it's a great pleasure. This is my 4th year, right? I think I've been here every year. And it's fantastic to start seeing more and more familiar faces. This is pretty nice. And so thank you for having me. It's always a pleasure. So I'll try to make this shorter. So I believe you're going to have the slides. So the major concept here is that we have to acknowledge that relapse is still a problem after allogeneic transplant, okay? Although we, as Dr. Moti pointed out, we strongly believe in the graft versus leukemia effect, especially for patients who are transplanted in advanced state of disease. Relapse is still a problem. So that's the assumption number one for us here. This slide I've been showing here almost every year. This is Singapore, the APL boat. This is the AML boat in Montreal, looking for the MDS boat. So if somebody has it, let me know. So we're going to talk a little bit about relapse. And we thought about the ideal agent, as I mentioned, if we can come up with something like that. And the idea is to talk about myeloid leukemias. We do have a model. If you think of chronic myelogenous leukemia, you have a reliable marker for relapse. You do have a reliable biologic way to monitor CML, right, with BCR-ABL. And you do have interventions that are very good in the form of donor lymphocyte infusion or TKIs. The catch is, for these diseases, we don't have that. That doesn't exist. So let's think CML. Now, why would we want to prevent relapse? Well, don't need to tell you that, right? But the main message is we cannot treat relapse very well once it occurs. Keep that in mind. So I listed here a few strategies, if you will, to prevent relapse. One of them, and I'll talk a little bit about it, is a strategy used by the Germans who basically monitored CD34 chimerism. So as the donor cell chimerism was dropping, they gave them Azacitidine to revert the drop in chimerism. So we'll talk a little bit about that strategy. Maintenance of remission, which is the major topic of my presentation. One can obviously improve the conditioning regimen, but we don't have time for that. Dr. Moti touched a little bit on that. We can improve the graft, which is obviously a very important thing. Several strategies come to mind, such as selecting tumor-specific T cells and try to expand them ex vivo and use them to bypass GVHD. And obviously, you can select patients, right? Just don't transplant high-risk patients. But that would not quite work with AML because most are high risk. So anyways, that said, this is a scheme of this German trial that I mentioned that used azacitidine in full doses to try to revert this dropping chimerism. So I'm going to just leave. I'm not going to detail this. You have the slides. You can see it. But suffice to say that several patients did prevent relapse with this aggressive strategy, okay? Let me see. So let's talk a little bit about the maintenance of remission, which is the major topic of my talk. Recently, actually, I would recommend, if you folks have access, recently we held an NIH-sponsored, the second relapse post-transplant symposium in Washington, D.C. It was a very nice opportunity to interact, and there are slides and there are proceeds from this meeting somewhere online, so you may want to look at it. And soon there will be in Biology of Blood and Marrow Transplantation a series of papers revising and summarizing the procedures of that. But you can see here some candidate agents, right? We can use FLT3 inhibitors after transplant. We can use histone deacetylase inhibitors. Although these agents seem to reduce graft versus host disease, it's unclear if they do reduce relapse. I'm going to talk about Vidasa, azacitidine, and you could think of lenalidomide as well, keeping in mind that lenalidomide seems to cause a lot of graft versus host disease. There are other monoclonal antibodies that are coming very strong, although here we're talking more lymphoid malignancies. There is a new class of medications that you should keep in mind, which includes anti-CTLA-4, anti-PD-1, which are antagonistic, and they may lead, these are all agents to some extent will intervene with co-stimulation of T cells between antigen-presenting cells and the T cells. So these are very interesting agents that are soon to come to our arena. What else? So here I created a few tenets, if you will. What would you like to have in a maintenance agent, okay? So the first one is obviously show that the agent is somewhat active. So let's talk about that a little bit. So back in 2003 or 4, we decided for a variety of reasons, and I'm going to come back to that, to use tiny doses of azacitidine to treat relapse, to treat AML relapse. And I'm going to show you one case of that, which you wish would happen all the time like this. So this is a young lady with flat tree disease, AML. She relapses approximately 6 months after transplant. So this is platelet count going down. You can see here she's now mixed chimera, right? She's losing donor cell chimerism. So she receives Vidasa at 32 milligrams per meter square for 5 days, one cycle. And you can see here the next marrow, she's already back to deployed cytogenetics. She's male cytogenetics again, gets a second cycle, and the platelets start to go up. We have not even tapered her tacrolimus. This is the mark down here. She's still on immunosuppression. And after essentially 2 cycles, she receives a third, and now she's back completely chimeric and in remission. So we bridged this young lady to transplant without cytotoxic chemotherapy, without any other intervention. This was, obviously, you wish this would happen often. It seems to happen in 20% of the cases for indolent relapses. Rapidly going relapses, this is not going to help. But it seems to help some patients when they are with sort of a MDS type of picture after transplant. What else? You wanted this thing to be not toxic, right? This is after transplant. These marrows are very frail. So whatever you give, it can cause pancytopenia, myelosuppression. So you got to be able to do it early, but you got to be able to avoid toxicity. This is very important. So we did a phase 1 trial with assumptions that I'm going to show you here. I don't remember if I said this last year, but it's interesting how we go. There are fashions, right, in medicine. So look at this, decitabine. Look at the astronomical doses of decitabine we gave. This is back in the late 90s. We had no idea about methylation, right? That lower doses probably are much better. And we gave this astronomical doses of decitabine together with Bucy. And actually, these patients did well, but I joke that this is the annals of forgotten trials. Nobody remembers it. So at the same time, J.P. Issa at MD Anderson said, no, you're wrong. You should give tiny doses of decitabine, 20 milligrams per meter square, instead of 800 milligrams, and achieve similar results. So say, hey, maybe we can do this for transplant. So then we designed a phase 1 trial in which we said basically that lower doses of AZA would decrease relapse rates. And I'm going to tell you very briefly about this trial. Essentially, people received Myelotarg, 2 milligrams per meter square, fludarabine melphalan, and went to transplant. Okay? The median age here was 60. This is a phase 1 trial, basically. You can see here there were only 20% of these patients were in remission at transplant. The majority of them were not. And the first message from this trial was, considering how advanced these patients were, there was some signal that they could benefit from this intervention. Patients received azacitidine approximately 6 weeks after transplant, up to 4 cycles on this trial. And so here, there was a second signal that was very interesting. This is a Bayesian thing, so the higher the number, the more likely that there is a beneficial effect. And the more cycles they got, the less chronic GVHD they had. So, hey, this is interesting. This is a phase 1, so we said, well, let's follow on this. So here, we learned that we could deliver the drug. The maximum tolerated dose was 32 milligrams per meter square, given 5 days subcutaneously. And then we started a randomized trial, which is ongoing, that has approximately 100 patients at MD Anderson. And at the dose that I told you, patients are receiving maintenance for 1 year, and the other arm does not get maintenance. So we hope this trial will confirm this hypothesis, but remember, this is investigation. What else? We're giving cells after transplant. What happens to the donor cells, right? Or we're giving Vidasa after transplant. What happens to the donor cells? So there's a whole list of interesting activities that may or may not be happening. It's interesting to remember that since 1984, we know that, for example, giving Vidasa to blasts in vitro increases the expression of HLA class 1 and class 2, and also does this differentiation effect, if you will, where you increase some tumor antigens. Conceivably, this could increase the graft versus leukemia effect. And there is also some effects that Dr. Singrit Parmar is studying, for example, on the microRNA function, that may have immunosuppressive and actually some anti-tumor effects. And also some effects on the FOXP3 gene. You may or may not remember this, but this gene determines the fate of lymphocytes towards a T regulatory phenotype, which may decrease GVHD. So let me speed up here. You folks want to have the slide. This is Singrit's work showing that in a few patients, in vivo, in human, you take these cells here, you can see the phenotype, and you do decrease, with low dose azacitidine, you do decrease methylation levels at the promoter of this gene, which conceivably could lead to this T regulatory profile, okay? Also, in vivo, in humans, the British, with our data here, they started a multi-center study. This is led by Charlie Craddock in Birmingham, in England, that essentially used the same idea, Vidasa after transplant. And what they showed that there was an induction in humans in increasing circulating Tregs early on, and some memory cells that are also anti-tumor memory cells. So suggesting again that the drug may have this immunomodulatory effect that may be favorable for us. And this is just a summary of what I said. I'm going to skip this slide. And I want to briefly mention another study. This is retrospective. This is not randomized. This is from MD Anderson. While I was still there, you notice that I left MD Anderson, so this data is all MD Anderson generated, not from my new institution yet. Essentially, we look at historic controls on patients that received more than 3 cycles of maintenance with AZA. And the message is here. This is after 6 months, so this is a landmark analysis, and you see that there is less cumulative incidence of chronic graft-versus-host disease is lower for those recipients of more than 3 cycles of azacitidine. So again, this is non-randomized, but just suggestions, right? What is next? We are starting an oral azacitidine trial, so it's obviously very desirable for our patients to use a drug that can be given orally, right, instead of subcutaneously, especially for maintenance. So oral AZA has a similar profile, although, and this is sub-Q and this is oral, with the difference that the absorption is very low. So the idea here is that you can do a chronic exposure, right? And that may be better for maintaining low levels of methylation in some of these targets. So the idea that we're starting a phase 1 trial that is going to be basically at Case Western, at MD Anderson. We're going to be doing in Seattle, and in Birmingham, in England. So this is we hope that if we can pass diarrhea, oral AZA causes a lot of diarrhea, we will move towards a randomized international registration trial for this drug in order to prevent relapse after transplant. So I think it's fair that the post-transplant scenario used to be just GVHD, right? We just say, hey, we're worried about GVHD. Well, we may have new classes of medications now that may allow us to kind of pharmacologically manipulate a little bit within the limitations, obviously, of a clinical trial yet, the separation between graft versus leukemia and graft versus host disease. So we all hope that that would be the case. This is just to acknowledge my buddies at MD Anderson, and this is my email. So feel free to email. And this is my hometown in Brazil, which I think I showed every year here as well. Maybe one day you're all going to go to Brazil visit it. Thank you very much.
So I think with the limited time, I think we can take one or two questions, and then the speakers can be available at the time of the break, or you want to, why don't the speakers come on up here? Questions? Come to the microphone and introduce yourself. So let me start then. I'll ask Dr. Wang. Dr. Wang. So in your study with Homo Harrington, you used a very low dose of daunorubicin. Do you want to comment on that? 40 milligrams of daunorubicin, I believe.
Yes. So at first, we started dose with the daunorubicin at 40 dose. But after recruit the over 200 patients totally, we adjust the dose to the 45 milligram is the standard dose of daunorubicin. But at that time, the high dose daunorubicin, the trial the data not reported yet. So we still use daunorubicin at 45 milligram per square meters for that trial.
And so, because other groups have used now up to 90 milligrams.
Right, right.
Is there a concern about cardiotoxicity with Homo Harrington, or?
So the toxicity have also cardiotoxicity is not severe compared to the daunorubicin and the cytarabine alone. So there's no big difference.
Okay, thank you. Other questions for the panel? Everybody's still awake? Yes, back there. Go ahead.
I am Supano Chakrabarti from India. My question is to Dr. Delima about hypomethylating agents post-transplant. Now, all the studies now are concentrating on azacitidine. Have you completely gone off decitabine, or there is still some role of it in a reduced dose?
I wonder if they're here, but many years ago, when we started this, a group in Korea is conducting a trial. We talked about this, and they chose to go decitabine. As far as I know, it's the only trial that is using decitabine that I know of, and I don't know what's good or bad. Looking for the dose, and I'll tell you pragmatically, you know why we use azacitidine and not decitabine? Because there was not a single company that owned decitabine that was even vaguely interested in doing this. Remember, this is 2002, so when I approached Pharmion, and I'll be candid about it, Pharmion, hey, maybe this is a good idea. Everybody else said, what? We're not going to do this. This is crazy. And decitabine said, that's crazy. So that's simple. There is no reason to believe that decitabine would not have the same effect. I would just caution is dose. You gotta be careful, because it's like calling a bad name about your mother for a transplanter to burn a graft, right? So you come with a low high dose of decitabine and you kill the graft. It's like offending my mother. So it's gotta be very careful. That's my only advice. So you have to find a lower dose. It's not a chemo effect. It's an immunologic effect.
The second question is, conceptually, do you think a combination of histone deacetylase inhibitor and hypomethylating agent would be better than either alone?
Yes. The problem, again, is dose, because you remember that the histone acetylase inhibitors, most of them also can be myelosuppressive. So the doses that you think when you treat in AML or other situations, here you can't. You see, I'll give a simple example for you. You give this low dose of AZA, which is nothing, right? It's 15, 20% of your dose. You give ganciclovir to treat CMV. Counts drop like crazy. So it's how vulnerable this is. So you gotta be very careful. But that's conceivably, of course, that's a great association.
Okay, we have a question, last question over here, or?
I'm Dr.
two more?
T.K. Dorai
Yeah.
from India. My question is, Mohammed, what is the role of lenalidomide in elderly AML? Is there any role of lenalidomide in elderly AML? Lenalidomide in elderly AML.
Lenalidomide in elderly AML.
This from Mohammed.
Well, there have been case reports in small series, but I don't think that lenalidomide can be considered today as a standard of care, in elderly AML.
So,
Yeah, I think I have a quick question to Dr. Delima. I think that the concept of a maintain CR is very good, but my question is that which kind of patient you will select for the clinical trial, and when you will start the drug. And also, since you have initiated the clinical trial, can you tell me some initial clinical results, such as side effects, adverse event?
Let me start backwards. So side effects, very few. With this low dose, some injection site inflammation. You have to keep an eye on the site. Fatigue, and occasional drops in platelets, but not severe. So in terms of toxicity, is very minimal. The second thing is, what was the second thing? When do we start? Approximately 6 weeks.
What kind of patient you will select for the?
Most patients we included were patients that were not in remission at the time of transplant, but on day 30 marrow, they were with less than 5% blast. So the idea was not to treat a disease. At day 30, they should be in remission, meaning with less than 5, just defined by morphology. So, and we also, as we got less afraid, we start treating FLT3 patients, positive patients. We have been treating CR2 patients. So there are patients now that were transplanted, but they should be considered high risk. Either poor cytogenetics, the standard definitions, if you will.
I'd like to thank all the speakers and certainly Dr. Chien and Dr. Lazarus for chairing this most illuminating session. Thank you very much. We'll take a coffee break now and reassemble at 10:30 sharp. There will be more seats available for all the standees in the back. Thank you.